بسم الله الرحمن الرحيم. Benign asbestos-related pleural disease. The benign asbestos-related pleural disease include the following. First, pleural plaques. Second, benign asbestos-related pleural effusions. Third, diffuse pleural thickening, DPT. And fourth, rounded atelectasis. I will start by speaking about pleural plaques. Pleural plaques, most common manifestation of asbestos exposure. Pleural plaques are most common manifestation of asbestos exposure. Discrete areas of white or yellow thickening on the parietal pleura may calcify, and histologically these are acellular, avascular areas of hyaline collagen fibrosis. Bilateral and occur particularly on the posterolateral chest wall, particularly adjacent to ribs, over the mediastinal pleura, and on the dome of the diaphragm, but are absent in the costophrenic angles. Develop 20 to 30 years after exposure. Incidence, but not the extent of plaques, increase with longer duration of exposure, found in up to 50% of asbestos-exposed workers, and also occur after low-dose exposures. Usually asymptomatic, although if extensive, may be associated with mild breathlessness due to pleural restriction. Effect on pulmonary function is uncertain, and most studies have failed to demonstrate abnormal lung function, although otherwise unexplained mild airway obstruction or restriction has been described in some populations of asbestos workers with pleural plaques. The mechanism of this is unclear, although it may reflect asbestos-induced small airway disease or early interstitial fibrosis, respectively. High-resolution comparative tomography (HRCT) is more sensitive than chest radiograph (chest X-ray) in detecting pleural plaques. There is no evidence that plaques are premalignant. Asymptomatic plaques are no longer eligible for compensation in England and Wales, but are in Scotland and Northern Ireland. Tuberculosis, trauma, and pneumothorax may each cause single pleural plaques. Multiple plaques are highly suggestive of asbestos exposure. The second benign asbestos-related pleural plaques is benign asbestos-related pleural effusion. Relatively early manifestation of asbestos pleural disease and usually occurs within 10 years of exposure. Development is considered to be dose dependent, although can occur after minimal exposure. Typically small and unilateral, and may be asymptomatic or occasionally associated with pleuritic pain, fever, and dyspnea. Usually resolved spontaneously over a few months, although some recur in although some recur. The pleural effusion is anexate, often blood-stained, with no characteristic finding of pleural fluid analysis. Diagnosis depends on history of asbestos exposure and exclusion of other causes, including mesothelioma. Benign asbestos pleurisy may precede the development of diffuse pleural thickening That's to say, there is no clear association with mesothelioma. Treat symptomatically with pleural aspiration for breathlessness and non-steroidal anti-inflammatory drugs for pain. The third benign asbestos-related pleural disease is diffuse pleural thickening, which consists of extensive fibrosis of visceral pleura with areas of adhesions with the parietal pleura and the consequent obliteration of the pleural space. Unlike pleural plaques or pleural plaques, its margins are ill-defined and it may involve the costophrenic angles, apices, and interlobar fissures. Developmentals or development appears to be dose related and may follow recurrent asbestos pleurisy. On a chest X-ray, it may be definite as a smooth, uninterrupted pleural opacity extending over at least a quarter of the chest wall, with or without obliterating or without obliteration of the costophrenic angles. On CT, the pleural density extends more than 8 centimeters craniocaudally and 5 centimeters laterally and is more than 3 millimeters thick. Symptoms are relatively common and compromise exertional breathlessness and chest pain, which can be chronic and severe, may lead to significant restrictive pulmonary function impairment with normal lung carbon monoxide transfer factor, especially if the costophrenic angle is obliterated. Hypercapnic respiratory failure has been described. Pleural biopsy may be required to distinguish it from mesothelioma, and treatment is difficult, and decortication often fails to result in clinical or functional impairment. Treatment is difficult. Decortication often fails to result in clinical or functional improvement. Patients may be eligible for compensation. Last benign asbestos-related pleural disease is rounded atelectasis, also known as folded lung, Liskopski syndrome, or shrinking pleuritis with atelectasis develops as contracting visceral pleural fibrosis ensnares and then twists the underlying lung, resulting in distinctive radiological appearances of a rounded or oval pleural based mass of 2.5 to 5 centimeters in diameter. Asbestos exposure is the most common cause, although any cause of pleural inflammation may result in rounded atelectasis. Asbestos Asbestos exposure is the most common cause, although any cause of pleural inflammation may result in round atelectasis. CT is often diagnostic, demonstrating a comet tail of vessels and bronchi converging toward the lesion, adjacent second pleura, and the volume loss in the affected loop. Atypical An atypical appearance may require positron emission tomography, PET-CT, plus or minus biopsy to exclude malignant disease. Typically asymptomatic, although breathlessness or dry cough may occur, usually stable or slowly progressive, and no specific treatment is required. Surgical decortication may improve the symptoms, but frequently results in reduced lung volumes and is not generally recommended. That's all, thanks.